Welcome to the Taylor Method for Pain-Free Living, a podcast that features enlightening conversations with experts in the medical field that helps to improve the health and well-being of those suffering from chronic pain due to injury. Learn from leading authorities the questions you should be asking to experience pain-free living. Hosted by father and son, Dr. Derek Taylor and Dr. Hudson Taylor, and joined by industry professionals in the health field, including doctors of integrative medicine and personal injury attorneys. Enjoy well-rounded and informative conversations to help you get out of pain while achieving optimal wellness. Dr. Derek Taylor and Dr. Hudson Taylor are the doctors of Taylor Chiropractic and Laser Center in Florida and California. Both father and son duo have earned respect and a solid reputation for successfully helping people transform their lives by assisting them to discover the hidden causes of their painful health challenges, leading them to experience the resolution of their problems using the Taylor Method. Tune in each week to learn about the Taylor Method, Dr. Taylor's proprietary technology that looks at the whole person and identifies the root cause of pain while facilitating natural healing and helps to restore the body to optimal wellness without using drug injections or surgery.
I'm here with Dr. Abhinav Gautam here in Miami, Florida. He has an office in Miami, Florida, and Los Angeles, California. And he does some very interesting treatments with helping people get out of pain. And I'm going to just kind of let him take it from here. Dr. Abhi, welcome to the show. And just would you mind just telling us a little bit about yourself?
Sure. Firstly, thanks to both of you for having me. Really looking forward to connecting with your audience today. So I'm an anesthesiologist by training. I trained at the University of Miami. Kind of been an entrepreneur my whole life. So during residency, I started a software company. Luckily, I sold it, 4 or 5 years later. Then I started another one. And then kind of that's brought me to where I am today, which is, I think, we're at the forefront of using placental allograft tissue. So basically harnessing the life force inside of every woman and figuring out new ways to use that in the body. And the gestalt of what we're talking about is the following. And it's really fascinating. When a sperm and an egg meet, it's basically invisible. And then 9 months later, you have a baby, that's like invisible to 10 pounds in 9 months. And then let's say from birth to death is, let's say you're a 10-pound baby, for example, and then you become a 200-pound man, that's only a 20x increase in your biological mass in, let's say, 80, 85 years. So clearly there's a very robust mechanism of cellular replication that's happening in utero. And that's essentially what we've tapped into, which is we identify, or rather, the goal of what we're trying to do is, let's say somebody comes in with shoulder pain, for example. I found that most people don't have an obvious problem on MRI when it comes to pain. Let's say maybe 20, 25% of people have something that's, okay, we need to operate on this, and this is what's causing this. But usually it's something non-specific, and then patients kind of then start, usually a very kind of non-linear path to relief, right? They're going from one doctor to another. One person tells them one thing, another person tells them something else. So what we're trying to do is reconcile somebody's suffering with what we see on ultrasound. And we're using very high frequency linear ultrasound probes. So unlike the obstetric ones, right, that are convex and are giving you like a window like this, right? The linear probe gives you a very accurate window, not as deep, right? But again, the problems we're finding aren't as deep as people think they are. So, so somebody comes in for shoulder pain, we scan them, we see that there are tissue abnormalities that line up with what they're talking about. And I don't know if this is a good time, but you can redirect me if it's not, but pain, at its essence, we really have to understand what kind of pain somebody's feeling, right? Because there's different types of pain. And it's super important, at least in my opinion, to kind of really ask a couple more questions when you're talking to somebody, and really try to get a real good understanding of, okay, is this pain in the shoulder something that's just dull and achy all the time, or is this something that when they're trying to reach for their coffee mug, they're getting electrocuted, in the front of the shoulder, and they're, takes their breath away, right? Those are, at a high level, two very distinct types of pain. One, which, clearly there's a nerve that's entrapped somewhere, likely a cutaneous nerve. But the first one was more mechanical transduction of this abnormality, and that's an abnormality in the amount of tension that's being applied to the tissue. So this is like mechanical transduction of signals, right? So something similar, if you just squeeze somebody's hand or arm for any extended period of time, right? Like it starts to not feel good at a certain point. So, our first step is understanding what somebody's going through. The second step is seeing if that matches up with the ultrasound scan and the rest of the physical exam and history. And then if those things line up, then what we're doing is we are creating fetal microenvironments in various parts of the body. So I'll just stick with the shoulder for now. So we would identify the shoulder, find, and usually see, in doing this now, I don't know, probably close to 4,000 procedures in the last 4 years. I don't think I could maybe count on one or two fingers the amount of times somebody's come in saying there's a problem, and then when we scan them, we see everything looks normal. Like usually people aren't crazy, right? And that's another thing that I've learned is that you really have to give people the benefit of the doubt when you're talking to them about pain, right? Right. They're not all malingering looking for OxyContin. There's people are just trying to figure it out. So the procedure involves, identifying these areas of tissue that are abnormal. Let's say in the event of somebody who's having that burning kind of pain, we can consistently and identify the plane which these cutaneous nerves are traveling in, and then we've developed a technique kind of rooted in what's called hydrodissection, where you take a needle, like a 25 gauge needle, you get into this right kind of millimeter plane, and then you start injecting this fluid. We have our own recipe that again is anchored in these placental proteins, and we're able to remodel and interact with the soft tissue in a way that we're trying to restore it as if somebody would restore like a fine painting. We're not adding anything that's not supposed to be there. We're definitely not cutting anything out, right? This is incisionless kind of procedures. But what we are trying to do is restore the integrity of the soft tissue. And when injuries occur, the main thing that happens is right, you get this acidic environment, and then the tissue dries out a little bit, right? Or there's bleeding that happens from trauma, and then platelets and fibroblasts come in to plug the hole and then lay down a bunch of collagen, and while I think a lot of times we think collagen we associate that with always being a good thing, in actuality, an overproduction of collagen can be a bad thing, right? If it's in a particular layer where it then starts affecting range of motion, right? Let's say like in frozen shoulder, you see that a lot, right? Where people then get kind of stuck, right? Their humerus is like stuck in the wrong place, and then that's a huge problem. Or like a cutaneous nerve entrapment type of situation.
Got it. So in summary, then, what you're saying, that's fascinating, by the way, I think this is amazing what you're doing. So in essence, somebody comes in with pain. Let's say I'm a new patient. I come to see you. First thing you do is you got to figure out what kind of pain is that. You take taking a thorough history, and is it a dull pain? Is it a sharp lancing-like pain, or whatever? It tells you what level that the pain is coming from, correct? Mm-hmm. And you developed your own, I'm assuming your own diagnostic ultrasound that doesn't go with the breadth, more at the width to see because that's where the problem lies. It's more on the superficial level and a broader length, so you can see that, because you might have the pain right here, but you may discover on your ultrasound that it's coming not exactly at the spot, right?
Exactly right. That's exactly right. Yeah.
And then from that diagnostic ultrasound, you're going to be able to pinpoint where to put and you're using placental material, which is a form of stem cells, I take it, to help regenerate that area and to because they have damage that, let's say they were in a car accident or they were in a sporting injury, when you say, they're going to separate those fibers, when you're saying it's laying down collagen, it's laying down scar tissue, correct?
That's right.
And then too much scar tissue is going to shorten that tissue and make it non-functional.
That's right.
Solution is you're putting the injection in there, which is going to help remodel and kind of regenerate that area, and so that tissue goes back to normal length.
That's exactly right. Yeah, that's exactly right. So just a minor minor kind of add on to what you said. Basically, 100% correct. What we're doing though, we're not injecting stem cells. We're injecting these placental proteins. And it's So the difference is, and this comes back to what I was originally talking about. So, when gestation is happening in the womb, the inner lining of the placenta is called the amniotic membrane, right? And it is basically like an immune privileged force field. And what that means is that without that wrapping around the fetus, the mom's own immune system would attack it, right? Because it's a foreign body. So this layer is like completely modulates inflammatory activity, but then it's also simultaneously secreting this magical recipe, right, of proteins that's found in the amniotic fluid. So what we're doing, and so amniotic stem cells, right, there's only two cell lines that are technically immortal inside the body, right? One is the bad kind of immortality, right? That's cancer cells that are replicating out of control and basically stealing nutrients from the healthy cells, right? And another are amniotic stem cells, because they have, and what makes them immortal, the amniotic stem cells have infinite amounts of telomerase, right? Which is the enzyme that is responsible for keeping the telomeres, so the end caps of the DNA, of an appropriate length, because we know that with each division of the cell, right, those end caps get a little smaller when the DNA comes apart, gets replicated, and comes back together, right? That it gets a little shorter, and once the telomeres get to a certain length, you start having mutations that can spontaneously occur during cell replication. So amniotic stem cells have infinite amounts of telomerase, which I like to think of as like spell check for DNA, making sure the words are right, so that there's no errors. So these cells have infinite amounts of this stuff, which is why you're able to go from a sperm and an egg to a baby in 9 months with no errors, and it's the first 3 months when all the complicated stuff is getting laid down. Yeah. So they have just discovered, maybe 5 or 6 years ago, a new kind of cell in the body called the telocyte, Telocyte, which basically kind of means like time cell, right? And these telocytes have infinite amounts of telomerase, and they're found kind of all over the body, and they're a really interesting cell that looks kind of like a nerve cell, but also a stem cell at the same time. And these cells are able to induce cellular replication, chemotaxis. They can recruit cells to an area. Essentially, they're kind of like this master watcher cell that has a profound ability to induce cellular healing and regeneration. So what we figured out how to do are turn on these innate stem cells inside of us by creating or tricking the body into thinking it's in the womb versus 2022. And we're essentially turning on your own machinery to heal yourself, right? And providing the right instructions vis-a-vis this recipe. And the amount of volume that we use is completely different than traditional stem cell therapy. For example, in the shoulder, we will use anywhere from 100 to 150 cc's of fluid, right? Which is completely counterintuitive to what most people would administer, which would be like 20 to 30 just in the joint space. But again, we are remodeling, as many layers of the soft tissue as we see is necessary. And to your point, let's say 90% of what we're doing is 3 centimeters less. So 1.5 inches,
Wow, that's fascinating. So what you're using though, is that unique to the regenerative medicine industry, or are other doctors using this in a different application?
Yeah, so the company that we use is called Tissue Tech. They're founded by a Harvard-trained ophthalmologist, Miami-based company, as luck would have it. But throughout this journey, I've tried, maybe 15 different vendors or so. We even put a lot of them through our own ELISA test to see, what was inside of each different product. And Tissue Tech is just the most scientifically rigorous company that I've seen. And there are other people using this stuff. Amniotic membrane was kind of discovered by ophthalmologists, I think, at the beginning of the 1900s. But it was only until the early 2000s that people figured out how to prepare these grafts in a stable way. First, they were cryopreserved, right? And now they are prepared in a micronized form. So that means they come to us in a powder that's room temperature stable. It has like a 3 to 5 year shelf life. So the other people are using them. Ophthalmologists use them to heal or prevent scarring, during a cataract surgery, for example. I started kind of experimenting them with my neurosurgery friends. We were trying to figure out how to reduce the inflammation on the spinal cord and in the brain when they were doing these operations. And I started to see that the scarring was massively reduced. And that really got my mind working on, well, where else can we use this? Maybe we can use this in the fascia, right? Maybe we can use this in the muscle.
So you're using this primarily for musculoskeletal pain. Do you use it in different applications as well?
We've tinkered and tinkering with, some cosmetic applications of it. Again, with the thesis being, if you're remodeling the superficial layer of tissue, which is the fascia of a human, which if you kind of think about a car, right, what is the body paneling of a car called? It's called the fascia of the car, right? I mean, when you start peeling back a car, whether it's a Ferrari or a Kia or whatever, the brand is irrelevant. They all have essentially the same core components. Just like human beings, we have a heart, spleen, lungs, blood. A car's got an alternator, an engine, brakes, exhaust, the same kind of situation. So it's really focused on this myofascial layer of the body. So where this connective tissue and muscle are interacting, is where we kind of hone in most of our focus, because primarily the cutaneous nerves are traveling in between the fascia and the skin. So let's say you have skin, fascia, muscle, right? Like 3 layers like this, right? Those sensory nerves are on, let's call it layer 1. And then, most of the motor nerves are below the fascia, above the muscle. So if you have somebody, we've had like Olympic cyclists that come in who have, extremely tight hip flexors, right? And we know of, 3 or 4 nerves that are coming out, starting from the iliac crest, so the side of the hips, that, from that going to the groin coming forward, where nerves are coming out, all over, right? And are responsible basically for the feeling or sensation of the legs. So when a cyclist comes in kind of complaining of some weakness and their legs are going numb, we don't go to the back first. We look at kind of the periphery first, right? Yeah, because it's kind of a backwards way of looking at it, but I really feel like the human body is such a robust, divine machine that I kind of go like low-hanging fruit. Okay, so if this person's an Olympic cyclist, let me first look in these other areas. They're sitting on a small seat, they're bent over, the legs going up and down. It's a higher probability in my mind, that the problem could be at one of these choke points, right, where the nerve's coming, basically through the hip flexor or on the side of the hip or what have you. Let's look there first and see if that's abnormal or normal before we go down this deeper, wild goose chase of, okay, you've got a disc problem, and then kind of going down that pathway.
So would you say that by improving the functionality of the connective tissue and bringing regeneration to that is taking pressure and alleviation off of the cutaneous nerves, which is allowing for greater function and less pain?
Yeah, that's what we're seeing. I can share a pretty interesting clinical story, if you guys want to hear one, about, let's call it, chronic nerve damage. So I have a friend, she's an equestrian, real famous rider. She gets thrown off of her horse and basically, shatters her ankle. So, it's basically chronic, regional pain syndrome is what her diagnosis is, because, after the surgery, she's left with a situation where she's like hyperalgesic, she can't even sleep at night because if the sheets touch her foot, she's like screaming in pain. She goes and sees a bunch of specialists in Los Angeles. They said basically, this is the cards that you've been dealt. There's nothing we can really do. We put the bones back together, but, this is kind of part and parcel with your injury. She's obviously extremely depressed about that kind of news, right? Because writing is her life. We crossed paths, and I think it took us, the first session, the pain was reduced like 50 to 60%. By the third session, is basically zero. And now she's, she just won the Miami Grand Prix. I don't know. And so she's riding extremely well. And, what did I see, right? When I scanned her, I saw, the bones had been put back together. But, when you have like a crush injury or like a crazy blunt force trauma that happens, the massive amounts of swelling that ensues starts to distort the anatomy internally, right? So if you went deeper than your skin and then inflated a balloon, right, or just put a bunch of fluid and caused a bunch of swelling, you can have tissue layers start to get stuck together from the inside out, right? So these nerves actually got transposed, and essentially, the sensor got moved closer up to the skin than it should have been, which is why it was being kind of like overly sensitive. So, we identified that plane, got the needle really in a precise plane, and then started remodeling this tissue, right? Like cleaving off the scar tissue that had gotten stuck and had trapped this cutaneous nerve between her skin and that dense connective tissue layer. In other areas, recreating the lymphatic system, which occurs in the loose connective tissue plane, which is right underneath the dermis, right? So basically trying to put Humpty Dumpty back together again.
Wow, that's amazing. That's truly fascinating, this process. Now, how many treatments does it typically take to resolve somebody's musculoskeletal condition?
Yeah, so great question. I think, and this is one of the things that we've learned over time is understanding who your patient is and, what their goals and timeline is or are, right? So I take care of a lot of professional athletes. Their timelines and goals are completely different than, let's say, the weekend warrior who just wants to be able to walk with his wife pain-free for 3 miles, right? So let's say both of those people are coming in with a pain scale of 8, NBA point guard maybe wants to take care of this in 2 weeks, doesn't really care how much it costs, but just wants to get out there, right? And time is of the essence. So there we're able to kind of work in a more proactive, aggressive manner. But, we're also very cognizant of the cost to the patients, right? We've self-funded kind of all of this work until very recently. It's just kind of like when new technology hits the military, right? You have this like trickle down effect. So we've kind of started in a market that, it's not covered by insurance. So for people who, let's say, aren't making, exorbitant amounts of money per year, we also, my goal isn't just for really rich people to not be in pain, it's for just to decrease the suffering burden that exists, globally. So for that weekend warrior, he may have an 8, maybe he wants to get to a 5 or a 4, and that's good enough, right? He may get there off of one treatment, it may take 2, it may take 3, everybody heals differently. Another rubric is kind of how long somebody's been dealing with a problem. You can kind of inversely to rewind out of that, someone who's had 30 years of back pain, and their tissue is all solidified, and, that'll probably take, 2 or 3 times, somebody who comes in, let's say with an acute hamstring injury, right? Or a nerve that's entrapped. I mean, we can probably get most of the way there off of one treatment cycle, which essentially is you come in for a treatment and then within 72 hours, we see you again. And if there's any fine tuning, we do that in that same kind of, same encapsulated patient experience.
Would you say the average number of visits is anywhere from 1 to 6 or so, or
I'd say like 1 to 3.
1 to 3 treatments. Okay.
Yeah.
Now,
and it's seemingly pretty permanent
okay,
in that.
but you talk about costs and everything. I mean, that's invaluable though, right? I mean, if they went to a physical therapist, it needs 36 visits, and they're still not going to solve the problem, right? And they're going to spend all this money. So the other thing is, you're using equipment that you have innovated, and you have a lot of costs. You have staff costs, you have research and development costs, and what you're doing, but it's invaluable. So whatever you're charging,
I'm with you, brother. I'm with you. I just
people gotta get out of the mindset that insurance is going to take care of their problem.
Yeah.
Right?
So look, I completely agree with you. However, I think we're in some really unprecedented economic times. So so the reason why I say that is, when somebody comes to the office and they ask me, all right, well, how many treatments is this going to take? I'm never prescriptively telling you, hey, it's going to be 4 treatments, because
you don't know how they're going to respond.
Yeah, exactly. Right. And you don't want, I've seen it where, you tell somebody a price and they're kind of freaking out internally and all this calculus is going on, really kind of trying to understand, this is something new. Is it going to work? I don't know, maybe I'm overly sensitive to that, but we're trying to in the most, respectable, just, straight up way with people, just work with them and understand, okay, this is your problem. This is what we're seeing. And now, we're going to treat it this way. If you have a positive response, then that means we're on the right direction. That doesn't mean that, you can't get better yourself after we kind of get you out of this predicament. Let's say we do one treatment and then the person is super diligent with their rehab, or they're working with great PTs or other docs, right? You may be able to get the rest of the way there. It may take a couple more months, right? But that may be okay to you. The NBA player maybe doesn't have that same kind of timeline. But I've started training another doctor. She was actually my first attending, Dr. Amy Kamat. So first time I went into an operating room, she was a lovely doctor that was kind of teaching me. And interestingly, life has kind of come full circle. And she joined the practice about 1.5 years ago. So we're now working together to build this kind of training framework. And another interesting thing we've done is we've created this AI called ScarMap that is analyzing the ultrasound and basically giving it a score, and decoding it, because we're trying to create a new gold standard of soft tissue surveillance, right? So MRI is great at a high level, right? But it's not sensitive, an inch below the skin, right? It's just giving you like a thick white chunk, right, of everything that's fat or water. So using and leveraging ultrasound, which is no radiation involved, you can essentially scan an area, and the AI is analyzing that area and basically giving you an interpretation, which is the tissue pliability, to use Tom Brady's, or to borrow some of his language. The pliability of this tissue has been decreased. A nerve may be stuck here, right? And we're starting to build the foundation, this technology stack that we feel is, front and center in getting this treatment, out to the world, right? Because we also want to create, or as best we can, reduce the learning curve for doing this procedure. It's taken me years to kind of refine it. I obviously want to figure out a way to onboard people into some kind of proficiency, and months to a year versus take someone 3 to 4 years to get good enough to kind of be competent at this, which,
how long did the treatments last for once you do an injection?
You mean how long is the relief?
Yes.
Yeah. So if we get to the root source of the problem, I can't say it's permanent because that would be lying, but patients from 4 years ago haven't come back, right? So it's, if you can identify, so that's why, again, the most critical component of this whole journey is taking that extra time and really examining a patient thoroughly, and asking them the right questions, maybe asking them a couple more to really dig in and understand what is the pain, where is this coming from, and then scanning them and seeing, can I reconcile what they're telling me with what I see independently, right? And then if those two things kind of correlate pretty tightly, then we know that the odds of success are really, really high. Then it just becomes a function of like the execution of the procedure. Like, did you get all that you needed to get? Was there enough volume delivered? Sometimes these problems, when tissue layers are really distorted, let's say from trauma or post-surgical scarring, those types of situations can take a little longer to resolve. But we're really happy with the fact that people aren't coming in on like a routine basis for the same problems. They'll come in for different problems, but usually I would say probably after 3 treatments, 95% of people are better.
Great.
The ones that are good candidates.
Is the Dr. Albie, is the treatment itself painful?
When I first was designing it and experimenting on myself, it was extremely painful because I hadn't I hadn't figured out the right recipe. But now it's basically painless because the process is, okay, we use like ethyl chloride to kind of cold freeze and stun the skin. Then we use a very small, basically tuberculin 30 gauge needle I use 2% lidocaine with a little epinephrine. Right, so you get a really dense kind of local block, and then there's a small amount of xylocaine, which is lidocaine with epinephrine, in each syringe that we're delivering. So the recipe that we've concocted consists of a carrier fluid that has basically, it's biomimetic to what's inside of your body. So isotonic fluid, right, that has all of the same serum chemistry and components that our plasma does. These placental proteins, and then a little bit of lidocaine in there to basically, the goal is to have this as painless as possible. When you're dissecting a nerve, you can kind of get a very transient, electrical shock, right? Like a shock per second, but that should resolve, in a millisecond or so. So if somebody has prolonged discomfort, that either means the amount of anesthesia that we're using is inadequate, or we would be in the wrong place, right? I mean, there was a very famous lawsuit that happened where a NFL, I think he was a linebacker or something, went in for a procedure, had a regional anesthetic done, but he was asleep. The anesthesiologist injected the anesthetic into the nerve, and then the guy had like permanent nerve damage. So when a patient is asleep, they don't give you that feedback, right? Our patients are stone cold sober, and they're there. So like, it's almost impossible to hurt somebody in that way because they would jump up off the table.
Are there any contraindications or risks in using your procedure?
So the main contraindication is if somebody has implanted surgical hardware. We typically don't, if you
like a knee replacement, total knee replacement.
Yeah. I mean, a knee replacement, less so. But let's say like you have rods in your back or that kind of thing.
Right. Okay.
Yeah. And the other risk is like really that it just doesn't work. I mean, the FDA packaging on the product is essentially it's approved for all soft tissue administration. No adverse events have ever been reported because, again, this is immune privileged material, so it doesn't set off the immune response in the same way even like stem cells do, right? So with some people, we've seen, including myself, when you are working in an area where you almost like reactivate a lymph node or like a big lymphatic chain. We were doing some work in my neck one time, and then I had, intense night sweats for like 12 hours, and I can only attribute that to this large amount of scar burden kind of being reintroduced to my kind of greater system, and my body kind of responded, by, okay, we got to take this garbage out. That's happened to some other people.
So for those that it doesn't work for, why do you think that's so? Is it because maybe the health of the patient is poor? They have not, their diet's poor, or their lifestyle factors that can have an influence on how the treatment take?
Yeah, I would say probably body habitus has a big thing to do with it. So we don't really work on people who are let's say, morbidly obese or very, very large people, right? Their connective tissue, they've got so many, like, you know, once you reach a certain weight, the amount of load that's being and pressure that's being applied to your joint, let's say your knee, right? Like, yeah, I could reduce or remodel, you know, your knee tissue, but if it's still going to be bombarded with, you know, a constant extra load, right? Your tissue is just responding to what it's interacting, you know, how you're interacting with the world, right?
Same with foot
So,
problems and any weight bearing issues. Or
yeah,
hip.
yeah. So yeah, for people on the heavier side, yeah. I mean, we treated, you know, everything, you know, from the head to the toes. It's just a matter of what exactly the problem is. So I would say, let's say for, you know, heavier set people, if they have a nerve that's entrapped, that's still a very straightforward thing. But when you start, you know, starting to remodel a lot of the soft tissue, and there's a lot of adipose in the way, distorting, you know, the kind of normal lines of tension, then that can be a little trickier. So, but again, it's typically, you know, we've gotten to a point now where if, you know, we have such a kind of thorough intake and process of kind of getting to know somebody, that when we then scan them, almost invariably the things line up pretty tightly, and then it's just a matter of doing the work. Now, people may, you know, they may have a suboptimal result and get discouraged or disillusioned if the right expectations and communication, you know, that isn't set from the beginning. So that's obviously, you know, something that you learn over time,
Sure.
how to communicate this kind of realistically, kind of set somebody's goals and expectations and figure out a plan to work with them. But, you know, I'm happy that we've, you know, over the last couple of years, we've kind of had those lessons, learned those lessons, and now we're pretty clear.
Once the anesthesia, I know that the procedure is painless, but once the anesthesia wears off, is there some soreness afterwards, like the next day or the next couple of days, or what can they expect?
Yeah, great. That's a great question. So that gamut can run from basically feeling no discomfort at all to exactly what you're alluding to, feeling like a diffuse soreness, you know, where the needles were working. If we were working, you know, in an area that there was a lot of scar tissue present, remodeling that tissue, that fluid will likely stay there longer than it would if it was less remodeling that needed to take place. So that kind of transient swelling can be irritating to the nerves, you know, and be you know, uncomfortable. But our post-procedural process, you know, we stay in touch with our patients, you know, pretty diligently. And just to understand from a trajectory standpoint, you know, is the graph of improvement looking like the stock graphs that we love, you know, like the hockey stick, like, okay, I'm a little sore, like nothing, you know, or is it something that's kind of tapering off, or worse yet, you know, something that plateaus where somebody maybe gets 50% relief, but there's still some lingering problem, then we like to have those people come back.
Dr. Abhi, I have one more question for you.
Sure.
Do your treatments also address the deeper structures as well, like the bone and the cartilage and the the menisci, for example, with bone-on-bone knees or torn menisci or cartilage damage?
Great question. So we do a lot of work with people's menisci. Bone on bone, we don't work on the bone specifically, but I like to tell people, you know, bones have no magnetic attraction to one another, right? So they only get, in my humble opinion, they only get bone on bone when something around them, or kind of, you know, a layer around them is pushing them together, right? Mm-hmm. So when there's a decreased amount of space that's occurring inside of the body because of unnatural or imbalance in the biomechanics, and then, like, you know, once the tension gets off, then the body's responding. I mean, the most common example of this is medial hip rotation, right? People are sitting, most of us, your hips start rotating inwards, right? The femurs start rotating outwards, right? So
you can treat the deeper structures by addressing the fascia and all the tissues that connect to it.
Yeah, that's that's the thinking. Yeah.
Thank you, Doc. Hey, I gotta go. I got a notification that just came up. I'm gonna leave you.
No problem.
Thank you so much, Dr. Abe.
Thank you. I really appreciate it.
Thank you.
Just turn your camera off, Doc. So I want to keep going because I'm fascinated with what you're talking about. It's supposed to be a half an hour show, but you know, our audience is just going to have to deal with it. I want to keep rolling. I'm so fascinated by what you're saying. I just have even more questions. If you have a few more.
Of course.
So,
Of course.
Yeah. So let's say you do a linear scan and you have multiple locations of damaged tissue, scar tissue formation, and collagen production. It's like, I mean, I know you have your artificial intelligence that says, hey, you know, there may be an entrapment here. I mean, how do you, and this may be part of the reason why our patients' expectations they may be disappointed because they don't quite get the results because there's just more work that needs to be done. Correct? I mean,
100%. Yeah.
So it's just, you can only do so much based upon your diagnostic accuracy and your abilities and your equipment and the fascinating information, the technique that you use. But the reality is, you know, sometimes people come in with, they're a hot mess, right? They're
a hot mess.
Maybe they're a figure skater or they've been doing martial arts and they're getting their body pounded for decades. And then they come to you and this tremendous complex bundle of scar tissue and stress. How do you handle those? And what do you know, talk about
I mean, that's a great question. So what we're really limited by is, so there's a, there's a certain amount of lidocaine that you can give somebody safely, right? Before you start, of local anesthetic that you can give somebody. So we use really low doses, but let's say you had a ballerina that comes in, that's 100 pounds or something, right? Their feet are, you know, completely mangled by what they've been doing for 15 years or however long they've been engaged in that activity. So let's say like their feet were just completely scarred up. That's a situation where we're basically limited by their body habitus and weight. Like we can only give so much of our fluid at a specific point in time. So that may be a situation, where we're like, hey, Sarah, you know, it's going to take 5 treatments because we can only give you 50 cc's at a time, or in somebody's wrist or their ankle, right? Where you are in kind of really tight real estate areas of the body where like, I can't put 100 cc's in your wrist, right? Your fingers will fall off. You know what I mean? Like, but like somebody's back or hip is a completely different situation, right? Like there's a lot more room to maneuver. So that's one of the things is, you know, where in the body are we talking about? You know, where is the problem located? That has a huge impact on kind of our cadence of care. But then also to your point, you know, the more distorted and damaged the tissue is, again, it's like, you know, reversing or unwinding a puzzle, right? Or like if 2 strings were knotted up in a couple different ways, you know, as you start unknotting them, maybe the first knot, you know, it maybe starts off like this, you undo it and then it like drops down to this, right? And then you undo it again and then it like further unfolds, exactly what you're talking about.
And then when you release something right there, that could affect some other part of the body and vice versa, right? And so
so the most important book I've read in my medical career, definitely as it relates to this, was not written by a doctor, but written by a fellow named Dr. Tom Myers, He's it's called Anatomy Trains, and it is the most fascinating book for understanding kind of the fascia and how this liquid crystal that sits over our muscle, right, it kind of is holding us all together, and how it's functioning, right? So you have these points of the body that are, you know, areas kind of where this fabric is kind of tacked down, right? So to your point, right, let's say if somebody is having pain in their knee, a lot of times we first look at their hip, right?
Yeah,
and we're able to kind of reposition their hip and realign their hip to their knee to their ankle. Well, then you're not having that vector of force coming across your knee and overloading the medial meniscus and medial ankle. and you're getting like ankle pronation, right? And
so you sound, the reality is you're not a technician. You're not just injecting, these dental cells. This is an art. It's an art form, right? And and your clinical experience and wisdom, you're taking into the account of the whole patient, looking at other areas of the body. This is all part of the reason why you do what you do and you charge what you charge, and to help people get the results that they're looking for. And the reality is too, I mean, hey, you're changing lives, right? Lives are being transformed.
I'm trying to.
So, I mean, how that value is.
Yeah, I mean, no, I'm with you.
But for those, I know that the burning question that a lot of people are thinking, okay, hey, I want to go see this guy. It sounds like the guy I want to go to, but just can you give them an idea of what the cost is for? I know you can't say, and everybody's different, right? And the circumstance. But what's a range that people would be able to? I'm sure you have payment plans that are available, or
sure. So my colleague, Dr. Kamat, she is a little more accessible, right? We're trying to create, I don't want to say tiers, but we don't want it just to be these super high-end people. But it's basically kind of analogous to what stem cells, high-end stem cells cost. So like, probably starts, let's say $8,000 to $10,000.
Okay.
Yeah.
And so, and then if they want to see you, I mean, you're the founder of all this, then they're gonna. It's like an understudy and the one who developed the procedures, right?
Yeah. Right now, I've over the last 4 years, I've probably done more free procedures than I've done paying procedures, and that's just part and parcel with when you're trying to figure new stuff out. But kind of where we are now in the life cycle of this is now I need to focus on, working with the rest of the team to advance the technology, as fast and as thoroughly as possible, because that is a core component in teaching this to more people, right? I want to get this out. We obviously ultimately want to get it covered by insurance, just make it accessible to people. There's clearly, unfortunately with, medicine, unlike, let's say, crypto or something, right? You can come up with a new algorithm and then spin it out and get adoption and have a huge impact in months, right? With medicine, it's a very protracted process to change practice patterns. But, look, the world is in too much pain. OxyContin is clearly not the solution.
Oh, wow. What about, can you talk a little bit about when people get these cortisone shots, injections into their joint, and talk about it from a medical standpoint? Tell us about it, because it's happening all the time. Isn't it frustrating when people come to your office?
It's absolutely the worst thing you can do. And
tell us why.
Basically, how cortisone works is the way you and I are communicating with English. Like, let's say we're two cells, we're talking back and forth, having this great exchange of what's happening, what's going on. If you were to hit the mute button, that's what cortisone does, right? So we would just be like,
that's a great analogy. I love that analogy.
So like, we're not understanding anything that's going on. So yeah, it's very transiently may help someone's symptoms, because if you're hitting the mute button, well, then the cells aren't releasing any cytokines that are impacting, that local environment. So yeah, you may get a decreased amount of swelling, basically. Like, you turned off the volume for whatever, a short amount of time, but then it always comes back. And kind of furthermore, right, we know unequivocally that, cortisone weakens tissue, right?
Yes,
because
absolutely,
that mute button isn't, it's preventing good and bad conversation from occurring. So it's preventing cells from communicating and healing one another, but it's also preventing them from, communicating about the bad things that are happening in their environment. So, look, there's a small amount of people that get a cortisone shot that get better and stay better, and God bless those people. And we just want people to get better, right? But I think most people should go into it with the realistic expectation of, okay, I'm going to try this once to see if there's like a Hail Mary that works, but I'm not doing it more than once, because then it's not really going to.
how would you define better though? Because their symptoms may be decreased, but I have patients come. We work with a lot of knee patients, so
Okay.
we'll take a bilateral knee shot, and we'll see the knee on this side. The joint space is like this, and I can tell them where they're getting the cortisone shots.
Oh yeah.
Talk about how it decreases not just weakens the tissue, but how it decreases the joint space and sets them up for
Well, for sure.
for like a knee replacement, right?
So yeah. So in that situation, what you're talking about is completely true, right? Getting high dose steroids injected into joints is a terrible idea. Because to your point, right? That mute button is causing a decreased amount of activity, right? And then that tissue essentially weakens and, can't respond to the load that it's being exposed to, and then, kind of degrades, right? So joint space stuff, yeah, I mean, that's a terrible idea. So I'm in 100% agreement with you.
Yeah. So tell us about your bang up cases. Tell us about, what you do better than anybody else on the planet as far as which conditions, if they got a certain condition, they got to go see you. Talk to your audience.
Yeah, sure. I mean, a great question. So, we have a really, really high degree of success, with hip, lower back pain, knee pain. So for example, especially people with like patellar tendonitis, right? Jumper's knee, maybe medial meniscus problems, and really kind of any, we've been pushing the envelope the last 4 years of kind of what we've tried. So we've tried, like basically everything from the head to the toes. We have, I think like the bread and butter musculoskeletal issues are ones that we're very adept to treating, but also like the more esoteric things. So where we really hang our hat is a lot of people come to us once they've tried everything else, right? Because you try all the more accessible, more known about things first, usually most people, and then if those things don't work, then you really kind of go into your Google rat hole, and then hopefully you find us or you read Tony Robbins's book, where there's a chapter about me in there. His book's called Life Force, and there he talks about how I treated his scar tissue and helped him through a lot of chronic pain that he was having for years, right? Because he puts his body through such an incredible amount of stress, jumping up and down on stage for 12 hours, his whole program is very intense. And in the book, right, he talks about a couple other people, some famous baseball players, Big Papi, David Ortiz, Miguel Cabrera. These are both of those players Miguel was still playing. David had just retired, but he could barely walk when I met him. Couldn't run, couldn't do anything, had chronic pain in both of his legs. He had gone to the best hospitals in Boston, and basically people had told him he was crazy. I think we worked on him 3 or 4 times, and you guys been pain free for years. So
he's NFL player, and professional players should be hiring you, flying you out to their.
Yeah, I mean, we're in the process of working with some teams now to try to kind of be an advantage for some people. But yeah, it's just something where you can't get discouraged. You have to keep pushing. A message to your patients is that if you're uncomfortable, the first thing is trying to really understand where your pain is coming from. Your body is telling you the signals or sending you these signals for a reason. And at least I can say from our standpoint that even when things seem hopeless, we're trying to be that hope for people, right? So hopefully it's another way.
What percentage of people that are living in chronic pain would you say it's due to the cause that you're talking about, damaged soft tissues and call? What percentage?
I mean, I would say, look, I don't know, but I kind of have to, my intuition tells me like Pareto's principle. So probably 80%, 80-20 rule, probably.
Where's that other 20% coming from in your estimation?
I mean, look, ultimately the pain is really going to be caused by, a nerve that is compromised, or the general integrity of a area of tissue is compromised and distorted enough to where, right, there's too much tension being applied on an area, and then you get that kind of dull, achy, mechanical kind of pain. So, you know, I mean, I don't want to say it's 100%. Maybe there's some weird esoteric, you know, pathologies in the brain or the spinal cord that could be causing some of these problems. Or, I mean, look, there are people who have herniated discs, right, and the problem is actually central. So, you know,
can you help those people?
You know, it depends, right? We've worked on some people, but we haven't worked on a tremendous amount of people who have disc herniation.
Is that the same with central canal stenosis for people with bilateral leg pain?
Yeah, when you have like your yeah, exactly. So if we were to kind of work there, I mean, what would the intention of our procedure be? It would be to decrease the soft tissue load that is overlying the spine. You know, almost invariably you've got like a thickened rind of connective tissue, and that tissue is kind of what's compressing the lower structures. So we would do kind of like a soft tissue decompression, basically, and essentially, you know, you find the vertebral process, so that's the spiny part of the spine, drive the needle right to there, and then inject and try to lift the supraspinous ligament, basically try to pull, you know, everything that's attaching to it off to kind of give it more room to breathe.
So
but that's
you get good results with those cases?
I mean, look, yeah, we've had good results in the cases that we've done. But you know,
there's so many people that they have there's no solution for them other than surgery, right? Or roto-rooter surgery.
Yeah.
Wow.
Roto-rooter surgery.
So basically, anyway,
we gotta get you come down.
I'm in Palm Beach Gardens, so I'm not too far from.
Oh, really? Oh, yeah, absolutely.
Yeah, we have an office in Torrance, California. It's a suburb of Los Angeles. Sure. And we just opened up this office. We just opened in January here in Palm Beach Gardens, and right off PGA.
Welcome to Florida.
Yeah, we love it. It's great. Yeah, we got to go out to lunch sometime. I'd love to.
100%.
Yeah, it sounds like what you do is absolutely so fascinating. I want to know how I can refer some of my patients to you that are, you know, that are stuck and challenged and are not responding. Sure. And I'd love to. We're all about getting the patients the results, and if it's not with us, and somebody else like yourself. And so let's have.
So what I, you know, I think what we'll do is you know, I can find some time, either, you know, if you're down this way, or we have some PGA, you know, players up in Jupiter. So I could come up and visit you and actually do a procedure to you right in your office, and then you could kind of really get to see, and your staff could see what we're doing. Yeah. And as far as the referrals, you know, our website is probably the best place to go, which is vitruvia.co.
Yeah. So
www.
I'll cut this portion out of the edit, but
yeah, no problem.
You finish with the question. So, Dr. Abhi, this has been a fascinating interview. I can talk to you probably for hold you hostage for a couple more hours. I think what you're doing is so cutting edge, and this is what I think medicine. This is going to be the future of medicine, not just treating symptoms, but actually getting to the root cause and really bringing a permanent healing type of change to people, right? Not just
that's the intention.
So how can our audience get a hold of you? Tell us how they can contact you and
sure. So the best place would be going to the website, which is www.vitruvia.co. Okay. Or you could go to www.transforminglives.com. I think either of those things land. They both go to the same place, and then you can basically, there's a kind of a referral consultation link that you can click to, fill out some basic information, and then someone from our office will get a hold of you.
Great. And what's your telephone number so they can contact the office?
Oh, wow. Great question. Let me find out for you.
That's all right. They'll just go to your website.
Yeah, I don't know it.
This guy's so busy taking care of patients, doesn't even know his own phone number.
I don't know my own phone number.
You know, I one more question that I didn't add. That what about neuropathy? Are you able to help patients with neuropathy?
Yeah, so those people are very good candidates for our procedure, because that neuropathy is almost invariably being caused by a perturbation of a cutaneous nerve, as it's coursing through a particular area. So that is kind of to bring up Hannah's case, the equestrian who was riding. I mean, she had a horrible peripheral neuropathy in her foot. Neuropathy is something that we take care of a lot of. So
Great. So the neuropathy, that's actually in your estimation is due to the pressure on the cutaneous nerves from the soft tissues.
Yeah.
So,
or scar tissue that's kind of ensnared a nerve, or these nerves are traveling within the spatial plane. Let's say you have a muscular injury that's causing like a downward, basically like downward contracture, and then you're having like a stretch irritation of that nerve root. That's another.
So whether it's diabetic neuropathy or chemo-induced neuropathy or idiopathic
neuropathy? Well, diabetic neuropathy we haven't really worked on. This would be more just straightforward. Somebody is healthy, probably got injured, whether it's on the job or an accident.
An older person whose lifestyle, they're an alcoholic, they're diabetic, and they're
those people we haven't really taken. I can't say that.
But your diagnostic tool will be able to determine, right? If it's,
maybe.
If it's okay. Anyway, fascinated. This has been one of the most fascinating interviews here, and this has just been a real great pleasure for me to talk with you. And we do have we're only 45 minutes down the road, so we got to get together for lunch sometime.
Yeah.
I'll go down to your office or vice versa, and
maybe next week.
Okay, this sounds great. Look forward to meeting you sometime soon.
Yeah,
Thank you so much for joining the show. And any last words that you want to say to our audience?
I mean, I'll leave you guys with this adage from a Japanese philosopher named Murakami, and he says, "Pain is inevitable, but suffering is optional." And
that's a great.
And that's
you don't have to live with pain.
Yeah,
you don't have to live with pain. There's hope out there, and then what you just shared with provides a lot of hope for people. So thank you so much.
Yeah, doctors like us are, trying, just like you said, we're trying to get to the root cause of these things, because pain is your body telling you something is wrong, right?
It's a body signal. It's a body signal. Basically.
That's it. Yeah, that's it.
So don't ignore it. Take care of it.
Don't ignore it. It's like the fire alarm when it goes off.
Right. Yeah.
You don't ignore it. You find out where the fire is.
It's like the engine light that comes on in the car. You just put a piece of black tape over it so you don't have to look at it.
Exactly. And then when your car blows up, then you're getting all mad.
Exactly. So, hey, thanks so much for being on the show.
Thank you.
It's been a real pleasure for me.
I really appreciate the time. Thank you, guys.
Thank you for listening to the Taylor Method for Pain-Free Living podcast. For more information about the Taylor Method and how you can find lasting pain relief, visit www.drderektaylor.com. That's www.drderektaylor.com.